is a pharmacist who is a postgraduate training in dialysis and clinical pharmacy work with a nonprofit dialysis provider. In 2010, she transitioned to the biotechnology company Amgen. For those of you who don't know Amgen, they really did do a lot of medical breakthroughs with helping solve the anemia problem back in the late 1980s, 89. I remember I used to get blood transfusions every 6 weeks until they invented an ESA to treat anemia. And she's working on some clinical research and educational initiatives. And we're really happy to have her here today. She's going to be talking about understanding secondary hyperparathyroidism. I can say that, and treatment options. So welcome, Debbie.
Thank you so much for having me. I'm Debbie Drayer. You can see here I am what's called a medical science liaison with Amgen, former dialysis pharmacist for a number of years after pharmacy school. And I worked in the Kansas City area in a chain of nonprofit dialysis units. And it truly was just one of the highlights of my career, being able to care for renal patients, and just really had no idea the impact that decision was going to make on my professional life at the time. So thrilled to be here. Amgen is thrilled to partner with you, Lori, always, and the RSN to provide education for patients and support. And again, just thrilled to be here. So we are going to talk today about secondary hyperparathyroidism, which, Lori, you said so eloquently. I may refer to it throughout the course of the presentation as secondary HPT or SHPT, just to make it less of a mouthful. But we're going to talk about the disease and how it develops. We're going to talk about treatment options and possible treatment changes that are in place, really, so far this year in 2021 and beyond. So let's go ahead and just get started. So what is secondary HPT? And really, in order to talk about this particular disease state, we have to just go back and start with the kidneys. The kidneys, as you are well aware, are important for many important body functions, right? The kidneys clear toxins from your body. They provide electrolyte balance. They're involved in the metabolism and clearance of certain medications. One of the very important functions of the kidney in its fully functioning state is the maintenance of calcium and phosphorus. And so we try to keep those, for a variety of different reasons, in a very well-controlled and sort of normal range. Now, when your kidneys fail, you start to see disturbances in all of the things that we just talked about, right? For obvious reasons. When they're not working as well as they're supposed to, they simply do not have the capacity to perform all of the functions that we would like for them to perform. Now, let me take a step back from the kidneys for a second also and describe to you another organ in your body that we're going to talk about. And then I'm going to link the two together. So let's talk a little bit about the parathyroid gland. Okay, so you may be familiar more so with your thyroid gland. So when you go in for a regular, exam at your doctor as part of your normal physical exam, they will feel in your neck, right? And they will be able to touch as you swallow your thyroid gland. Now, there are glands that are very small that you can't feel, but they are right up next to your thyroid gland, and they are called parathyroid glands. Okay, so para as a prefix on a word means next to. So these are next to your thyroid gland. They are very small. So typically you're not able to feel them. Your doctor is not feeling them when they do your physical exam. But typically you have 4 in your neck. Sometimes individuals have more. That is not totally abnormal to have more than 4 glands, but nonetheless, they sit right next to your gland. They're moldable. They just sort of hang out there. And these are called, again, parathyroid glands. So when we're going to link these two together. So when your kidney function begins to decrease, as we talked about with calcium phosphorus balance, you have a disruption in that, right? And your calcium and phosphorus within your blood can get a little bit sort of out of whack. And when that happens, it stimulates your parathyroid gland to release its hormone called parathyroid hormone, or PTH. Okay, now PTH has a variety of different effects within the body, but primarily its purpose is to control the amount of calcium that's in your blood. Okay, so it does so, and we're going to talk about it on the next slide, but it does so basically by pulling calcium from your bones, okay? But once your kidneys continue to decrease in function, and particularly as you get closer to the stage of dialysis, your calcium and phosphorus is very out of balance at times. And it is a stimulus to this parathyroid gland to secrete more and more parathyroid hormone. And when that happens, your gland has this continuous stimulation for production of PTH, and it can tend to grow larger. So you see in these pictures here, on the left, in the middle, is these small glands, right, within your neck. And on the right, you can see with this kind of continued stimulation of calcium and phosphorus being out of balance, you can see there's just more and more desire for more and more production of parathyroid hormone, and that causes the glands to grow in order to keep up with that request for more PTH. And in that case, then you end up with these high parathyroid or PTH values that you end up talking with your dialysis care team about. Typically, this happens, again, like I mentioned, in the latter stages of CKD. As you're reaching stage 4 or getting closer to dialysis is when we start to see these PTH values really begin to rise to a point that we are more concerned about. Now, the reason that it is called secondary hyperparathyroidism is obviously the hyper, meaning too much parathyroid hormone, but it is secondary in this case to CKD. So that is where we end up with that name. Okay, so we talked about where PTH goes. Again, it is working to control or normalize the calcium in your blood. And we know that calcium and phosphorus are primarily stored within the bones. About 90 to 95% of those minerals are within your bone. So I like to think of bones as kind of a bank, right? Where you can go to the bone, your body goes to the bone to make a withdrawal of calcium or phosphorus. At the same time, you may have other situations where your bone is taking up calcium and phosphorus from your blood, okay? So in order to attempt to normalize the blood calcium values, PTH acts upon the bone and causes bone to break down so that calcium then comes out of the bone into the blood, and phosphorus typically follows it. So this process is good in a normal situation, right? This is happening in a normal individual on kind of a minute-to-minute basis. It is in those situations where we have, again, higher PTH values, where we are consistently going to the bone to pull more calcium out. We don't have that shut-off valve, so to speak, to show us that our blood calcium is normalizing. And so we end up having this negative consequence to our bone. Okay, so you do get some of the, like it says on the slide, some calcium and phosphorus from the foods that you eat, but primarily in a situation of secondary hyperparathyroidism, you are seeing a lot of the calcium and phosphorus coming from your bone at the stimulus of the parathyroid hormone. Okay, so you see this increasing blood level of calcium and phosphorus. So how do we treat secondary hyperparathyroidism in individuals? And this is across kind of the spectrum of CKD, and I'll try to acknowledge when we're talking about the whole spectrum versus when we're more specifically talking about the dialysis population. But we discussed on the last slide the contribution of your diet to calcium and phosphorus levels within your blood. You I'm certain, have been given dietary advice from either a physician or a nurse practitioner or a dietitian, more so within the dialysis unit, on dietary restrictions that may be recommended for you. So here are some examples of what we consider to be almost a first line recommendation, where we want to attempt, in a setting of secondary hyperparathyroidism where there may be an elevation in calcium and phosphorus, we want to try to limit high phosphorus foods as much as possible. And this is where a lot of counseling comes in from dietitians and from the dialysis care team to attempt to avoid as much as possible foods such as these. This is not an all-inclusive list, but dairy products, some dairy products like milk and yogurt and cheese are high in phosphorus. Dark sodas like Coke or Pepsi are high in phosphorus. And this is, again, kind of the first step that is almost always recommended in a setting where we need to start paying a little bit more attention and making sure that we are doing what we can to try to limit calcium and phosphorus elevations. Now, there are also medications. And this slide says if making changes to your diet doesn't work, and I would rather not necessarily think of it that way. I like to think of it as dietary changes are always important. We may reach a stage in this condition where extra help is needed, okay? And dietary restrictions are simply not enough to control the calcium, phosphorus, and PTH values. And in that case, you may experience a prescription of medications. So I'm going to start on the right over here with phosphate binders. So phosphate binders are very common, again, in the later stages of CKD when we're closer to dialysis. They're not recommended across the board in more of a CKD population, but phosphate binders basically try to block the absorption in your gut of phosphorus from the foods that you eat. So with that, you can imagine that they are taken generally with meals or with snacks in order to sort of cut it off at the source, right? When you are actively eating or snacking. And again, not recommended necessarily widely in CKD. We have quite a few guidelines that recommend treatments for secondary hyperparathyroidism. And in that case, usually these are reserved for closer to dialysis. On the bottom right here, we have certain types of vitamin D. This is used more to target your parathyroid hormone levels. Okay, so the phosphate binders clearly are targeting phosphorus, and vitamin D compounds are mainly targeting parathyroid hormone values. So there are a variety of vitamin D products that are out there. In the early stages of CKD, you may experience more of a pill form, an oral form that you take by mouth. And at the time of dialysis, generally, these are medications that are given via intravenous methods at the dialysis unit. So they're given while you're on the machine. And again, these are targeting your parathyroid hormone levels. Now, on the left here, we have a class of medications called calcimimetics, okay? And these are also primarily used to target the PTH or parathyroid hormone values, they do have effects as well to lower phosphorus and calcium values. So these are kind of, again, the three laboratory parameters that we're paying attention to, and calcimimetics tend to lower all three in the right direction. So these medications, there are two. One is a pill and one is, again, given at dialysis intravenously. These two are reserved solely for the dialysis population. So these are not medications that are used prior to dialysis. And so any combination of these can be used. You're not limited to just using phosphate binders. Typically, phosphate binders are going to be prescribed, particularly in the setting of dialysis, to the majority of individuals. Similarly with vitamin D compounds, at the point of dialysis, the majority of individuals are going to be on a vitamin D. And calcimimetics typically are added, again, when we need that little extra help alongside with all of this, the dietary interventions. But the guidelines to manage this disease provide a recommendation that all of these drug classes can be used as first-line agents when we are attempting to manage secondary hyperparathyroidism. And again, a lot of times you'll find that a combination of them is often necessary. Okay, so how do you know how you're doing? How do we know? A lot of times we may not even know that this disease process is happening, that we have the condition of secondary hyperparathyroidism, because it can often be somewhat silent, meaning that it is not always associated with symptoms. So how do we know how we're doing? Well, the guidelines have recommended for us, based on data from clinical trials and from studies that have happened over time, there are goal ranges that we are trying to target for PTH, calcium, and phosphorus in your body. And you will experience routine blood tests, whether you are in a setting of CKD or on dialysis. The frequency differs based on not only the blood test, but what particular setting you are in. And those have recommendations associated with them as well. But there are goal ranges for each of these that we are attempting to target. And the goals are standard, basically across the board. Every so often, you may see a different target range of phosphorus for a specific patient, or a different target range of calcium for a specific patient. But in general, this is not something that is individualized. These goal ranges are recommended by the guidelines, and we pretty much stick to it for each patient. So your doctor and your dialysis care team takes these goal ranges and matches them up with your personal results to see how you are doing. Okay, so this helps determine any treatment alterations that need to happen. So if dietary control is working well enough, great. If not, then medication starts and stops are determined by your laboratory results, changes in dose, combination therapies. This is how you're doing. So I know in a setting of dialysis, the dietitians will come around and have these monthly lab reports, right, where they will speak to you about how your calcium is doing, how your phosphorus is doing, what your PTH values look like. Those may be measured quarterly. So you have an idea on these lab reports of how you are doing and how your condition is being managed. So the dialysis procedure itself, and I'm going to focus here on dialysis primarily, just in order to include all of the medication classes that we're able to utilize. So Medicare, in most cases, pays for dialysis for the procedure itself. as well as all of the treatments that are associated with the dialysis procedure, okay? So there is a payment that is a specific dollar amount that they provide to the dialysis unit for that procedure. And some of the money within this payment is earmarked kind of specifically for medications, namely for calcimimetics. And this payment method changes over time. And as new medications are added, approved by the FDA, oftentimes there needs to be an adjustment to this payment, right, to account for having alternative treatment regimens that are available. So this payment method, like we mentioned, was just updated in January of this year, January of 2021. And as with any change of this nature, may impact certain medications that either are available to you or that you have been treated with in the past and maybe have seen them change, over the course of this year as adjustments have been made. So I encourage you, as the last bullet here suggests, to speak to your doctor and your care team about why your medications may be changing, but maybe even more broadly, what your care looks like. How is this particular disease state, as well as others, this particular condition, how is it being managed? What is the best choice for you based on your laboratory parameters and how things have been changing over time for you? I encourage you to advocate for yourself with your dialysis care team and have this open communication about treatment parameters, how you are currently being treated, and how it changes over time. If you have concerns or questions about a change in your medicine, how do you handle this? Keep in mind that managing your care is a two-way relationship, right? Between your doctor or your provider and your dialysis care team. I know most members of the dialysis care team would enjoy having a conversation with someone who is engaged and advocating for themselves in order to maintain good health and keep tabs on the care that is being provided to you and ensuring for yourself that you are receiving the best care that you possibly can. And I hope that you all feel comfortable with your provider and your dialysis care team to ask questions and keep this open line of communication. So on the right here is just a couple of almost conversation starters, right? And this can be applied to secondary hyperparathyroidism, but it could also be applied to really any other condition that you have questions about, right? What medications am I currently taking? Why would my medications change? Is this current treatment that I'm receiving the best one for me, and how? And that gives you an idea and packages it all up for you in a nice bucket of ensuring for yourself that you have, that you're receiving the best care for your own individual situation. And so I will stop here. I hope that what you take away from today is that secondary hyperparathyroidism is a very common condition. We talked about the majority of patients being treated in one form or another for this condition, particularly at the stage of dialysis. It's also very important to manage this condition. We talked about how it can often be asymptomatic, and that can make it difficult, right, to focus and put the right emphasis on management of this condition. But we also talked about the effect on the bone, and there are other adverse consequences of it as well. So it's very important to manage this condition. And then again, I encourage you to advocate for yourself in terms of the treatments that are available, matching them up with the one that is best suited for you. And I encourage you very much to talk to your provider or your dialysis care team about your medicines and any conditions or concerns that you have. So again, thank you so much.
and a shout out to our corporate mission partners for making this happen.